Welcome everybody. So we're here today. To listen to Justin Knox talk on understanding and addressing HIV and substance use. And Dr. Justin Knox is an assistant professor of clinical implementation science and intervention in psychiatry and social medical sciences at Columbia University. His research program is focused on HIV, substance use, social network analysis, and mixed methods research, primarily among vulnerable and marginalized populations, including racial and ethnic and sexual and gender minoritized populations in domestic and global settings. Justin, as most of you know, earned his PhD in epidemiology from here, Columbia University, where he also completed a postdoctoral fellowship in the substance abuse epidemiology training program. He also has a Master's of Public Health and Social Medical Sciences from Columbia University and a Master of Sciences in Medical Anthropology from University College London and a Bachelor's of Art from Middlebury College. He also, interestingly, served as a Peace Corps volunteer in Swaziland, now Eswatini. Justin also has a K Award that is in the third year. And he's also multiple PI of 2 R01s and 1 R21. And I just heard today that might be a PI of a new project soon. He also has like more than 65 publications in really top epidemiology and substance use journals. He also teaches students in the social medical sciences department, has taught like for the past year or so, and has mentored several students at Mailman. So Justin, take it away.
Yeah, thanks. Yeah, no, thanks for the introduction and thanks everyone for coming. You know, as Sylvia mentioned, I've been at Columbia a while, but I'm always meeting new people and kind of excited to today kind of take you through my journey a little bit, maybe bring that background to life a little bit at first, and then sort of get into where I'm spending a lot of my time thinking today, as well as sort of directions for future research. So so as Sylvia mentioned, I really came into public health through anthropology. My undergraduate degree was in anthropology. I'd served as a Peace Corps volunteer with an interest in doing health work, and that led to me being stationed, as I call it, in rural Swaziland, which is now called Eswatini. And it was right just as HIV was becoming a generalized epidemic, but before like wide scale availability to antiretroviral therapy. So it was a very challenging situation. But while I was there, I as a volunteer, I started working with traditional healers. And that gave me the opportunity to have some very interesting conversations with them about how to bridge traditional and biomedical approaches to HIV. And I wanted to do research. I realized that I wanted to do research on this and to do it rigorously. So that led me to go get that master's degree in medical anthropology that you mentioned. And I got trained on how to do ethnographic research. So then I went back and I spent a couple months living with healers and having discussions with them about sort of the potential for cross-cultural collaboration on this, fight against HIV, and then published that article. It was my first publication. I had like no idea what I was doing, right? I took like 6 months to respond to the reviewers' comments. But it was accepted, because it was kind of innovative. Like it was talking about like, some unique perspectives and like what I was learning as I was having these discussions. But then it came to feel like very academic, right? Like I sort of published it and I had a lot of interesting thoughts and experiences about it, but it kind of made me wonder like, well, what can we actually do about this? Like how will this inform, efforts to prevent HIV and get people on treatment? So that led me back to New York City and into public health training, right? I first got a job as an HIV case manager, and then for the New York City Department of Health. And I noticed that everyone at the Department of Health who was doing applied public health work had been trained in public health, right? So I applied to the SMS program at Columbia. It seemed like a natural fit. I had the background in anthropology, and it was sort of bringing the social sciences to public health. And it was through that program that I came to realize that what I really wanted was more rigorous training in quantitative methods, right, in epidemiology. So I switched over to epidemiology for my PhD. But I was lucky to be able to stay at Columbia and work with many of you all and get trained by you all. And I got a job as a coordinator of an R1 study looking at community-associated methicillin-resistant Staphylococcus aureus, or MRSA, right, and its transmission throughout New York City. And it was an amazing arrangement, right, because as I was learning epi methods, I was able to apply them to this project in my role as a project coordinator, right? And we collected, combined, we analyzed survey data, we were collecting biological samples, both from people's bodies, as well as household services, as well as capturing data about their social networks. And we were able to conduct genetic analyses on all the biological samples, first using SPA sequencing, and then ultimately using whole genome sequencing, sort of as those technologies were becoming more affordable. And collectively, all that research, really helped us increase our understanding of the dynamics of transmission, of community transmission of MRSA, right? As well as the role of infection, right? Because people do occasionally get MRSA infections. So yeah, across those projects, I led and I supported 8 papers. And I just want to kind of summarize them briefly and sort of bring these pictures to life. But we found out that staph is highly prevalent, right? At any time, 1 out of 3 people will be colonized with staph in their nose. And then the more body sites that you sample, the more likely you are to identify staph, right? And we also saw that even though staph was common, about less than 1% of people would get an infection with MRSA, right? Because, it's more rare for it to have developed antibiotic resistance, and it can even lose that antibiotic resistance. And then we found that through the genetic analyses that, genetic factors were probably the biggest driver of infection. Basically, if you came into contact with an epidemic clone that had enhanced its infectability. And then we compared our samples, with researchers from other countries, and we saw there was a lot more diversity, genetic diversity in terms of the staph infections that they were seeing. And then once we were able to do genome sequencing and actually look with real granularity about how certain strains were related, we were able to actually create maps across the community about how MRSA might be spreading. So it was really, such a formative time as a student here and learning what all this meant. And then our sort of most impactful paper from that work was we were able to show that if you had MRSA surviving in your environment, so in those household items that we saw, that you were more likely to have multiple recurrent infections, right? And because we had infection as the outcome, like a clinically relevant outcome, instead of just transmission, we were able to get that into, JAMA internal medicine. And, I created those, Knox proportional hazards curves and the survival analysis. So it was cool to get to apply what I was learning to the research that I was helping coordinate. And then we also wrote a really nice review article published in Trends in Microbiology, sort of summarizing what we learned about the spread of MRSA throughout a community. And we tried to represent that with that visual, as well as opportunity to write a commentary in clinical infectious diseases, sort of about, now that we know about all this complexity of transmission, what should we do in the case when someone is having multiple recurrent infections in a household? So that kind of was all my day job, as I was as a PhD student. But my really, my main interest all along, and what brought me here was HIV, right? And I really wanted to continue doing research on HIV and being involved in this sort of fight against HIV in Africa. And that came to involve work with sexual minority men. One of my mentors in the SMS department is named Teo Sanford. He conducted one of the first cross-sectional surveys among sexual minority men in sub-Saharan Africa, where it's such a stigmatized setting, even though there's certain constitutional protections for sexual minorities there. And it really didn't know that it was possible to collect data and identify these men and interview them about their lives and their experiences with stigma, as well as their vulnerability to HIV infection. So together we published 6 different papers looking at stigma, sexuality, HIV related vulnerability. And we found mainly that, South African sexual minority men, they experienced high levels of stigma. They were at high risk of HIV transmission in terms of their behavioral profiles. We found that substance use was highly normative, especially heavy drinking, right? Nearly 2/3 screened positive on the audit C. And that Black sexual minority men, particularly those living in townships like the one shown here, which are these under-resourced areas that are sort of an artifact of apartheid, are really where men were at their highest risk. So that preliminary data paved the way for Teo to get an R01 study looking on HIV and sexual risk in Black sexual minority men in South African townships. And this was a bigger cross-sectional study and focused exclusively on those townships. We were also able to objectively assess HIV status, right, by testing them for HIV infection. And they used respondent-driven sampling, which was great for me because it's a referral-based recruitment strategy where you keep track of who recruited whom. And this allowed me to apply what I was learning about social network analysis to this data. And I was able to carve out my own sort of research program focused on social networks and substance use and how that contributed to HIV vulnerability. And under Debbie's mentorship, I wrote an F31. It got, funded on the first submission. And that, became my dissertation, right? We wrote a systematic review paper, sort of what had been done in the area, and then did 3 empirical analyses exploring the distribution of heavy drinking and then looking at how it impacted HIV risk behavior. I also leveraged that data and wrote a Fulbright grant as I was a PhD student. And that allowed me to go and spend 6 months in South Africa to live in those townships where that data for my dissertation had been collected, and really dig into this issue of why there were so few older Black sexual minority men who were participating in these studies, right? Because older men are more likely to be living with HIV, but they're not participating in these studies in a way that it's underestimating the burden of HIV infection in those communities. And it was a great project, right? Like, it sort of brought back my qualitative training. I was able to conduct in-depth interviews with over 35 men to talk to them about their social and their sexual lives. It gave me a much better appreciation for the context in which that dissertation data had been collected, because even though I'd served as a Peace Corps volunteer there, like many years before, the landscape had changed. And it was actually my first opportunity to serve as a senior author as a paper, because I collected the qualitative data and then I'd started teaching, as Sylvia mentioned. And one of my students wanted to do a practicum to analyze that data and write it up. And so it was really kind of like a full circle moment for me a little bit as I finished up my dissertation and sort of moved on to the next stage, which was to do a postdoc also here, also at Columbia, but in substance abuse epi, right? Focus was sort of more exclusively on substance abuse, and to really get more in-depth research experience working with Debbie and Sylvia on a lot of the exciting work that they do, working with nationally representative data here in the US, and also doing longitudinal analyses. So under Debbie, I had the opportunity to work with the Alcohol Clinical Trials Initiative, which is a work group that is looking to show the health benefits associated with drinking reductions using that NESARC Waves 1 and Wave 2 data, among other data sets. And with that group, we led 4 papers really exploring the health benefits associated with drinking reductions, measured using this World Health Organization risk drinking levels across a number of different domains, including mental health, other substance use disorder, in terms of cardiovascular disease, as well as liver disease. And it's a harm reduction approach, which excited me, right? It's showing the benefit of reducing your drinking, including the non-abstinence. And it also got me thinking not just about, what contributes to vulnerability, but what happens when people reduce harmful behaviors, right? And sort of getting into the next stage of my research sort of training and program, which is intervention, right? And what can we do to actually address these issues once we sort of have a better understanding of what's happening. So Debbie also asked me to lead this scoping review of the current evidence for preventing, screening, and treating heavy drinking and alcohol use disorder, and it was an invited review at Lancet Psychiatry. It was a great opportunity for me as a trainee, but also it turned out to be a really formative experience, right? Because it helped me really understand like the prevention, screening, and treatment landscape for this, issue of heavy drinking, something that I saw was clearly a concern among this population that I'd been working with in South Africa. And I realized it was a direction that I could go in when I was writing my KO1 award, right? To get into the intervention implementation science space. And that's really what I worked on as a postdoc. So yeah, the K award, I'm gonna, that's sort of present day in this journey. So yeah, I wanted to sort of bring together all these different training and research experiences that I had across these departments and divisions, and really think like, who do I want to be? Like, what do I want my research program to be? And how can I sort of tell a convincing story about this is what I've learned, but this is where I want this research to go, and how I want to sort of shape my research agenda. And what I came up with was this project, Intervening to Improve HIV Treatment and Reduce Drinking in Young Black Men Who Have Sex with Men. I'm now in the third year of my KO1 award, and I'm just gonna sort of jump into that project in a little more detail, sort of describe the work that I've done, as well as some of the work that it's expanded to already. Great. Pause for some water. Yeah, so for my KO1, I mentioned I wanted to build off the expertise I had, right, which was in HIV, substance use, social networks, working with racial and sexual gender minorities. And I wanted to get into intervention work, right, which I thought made sense in terms of what I'd been trained in. It was clearly a gap. And as I got into, discussions with mentors about wanting to do intervention work, they were saying, in this day and age in the HIV field, you can't really be talking about intervention without also thinking about implementation science, right? We want to find out things that work, but we also want to understand how people uptake those things that work. And, what are the barriers and facilitators to that? Are things getting implemented with fidelity once you, take them out of trial settings? And just really unpacking, how do we actually get people to use these, HIV prevention and treatment technologies that have shown to be effective. So, and it was an important moment for me too, because I'd conducted all that research in Africa, sort of always thinking like that was where the heart of the HIV epidemic was. And I read this article in the New York Times, and it really helped me understand that you didn't have to go to Africa to study HIV and to deal with, people disparately impacted by HIV, because the HIV epidemic among sexual minority men here in the U.S. is also incredibly complex, and really in some ways worse than in many African settings, levels of prevalence and infection over lifetime. And it really made me shift my thinking about where I could do my work and how I could, position myself for the future. And that article quotes a statistic, which I found really shocking when I first realized it, but like that, not only among people living with HIV in the US, 2 out of 3 are sexual minority men. But when you look at by race, you can see that, 1 in 2 Black sexual minority men will get diagnosed with HIV in their lifetime, and 1 in 4 Hispanic sexual minority men, compared to 1 in 11 white sexual minority men. So huge racial inequities. And it made me realize, like, I could really do this research that I'm interested, but also do it, here at home. And then I, just to provide some more background, I also started looking into this issue of alcohol use. And this is a paper I worked on with Sylvia and another postdoc. But, we really did see that there are just as high levels of alcohol misuse among Black sexual minority men as there are among any other sexual and gender minority group. And this is looking at using NISDU data to look at past month binge drinking. And then we also took that same data and looked at alcohol use disorder over the past year, and saw that there were similarly high levels among Black sexual minority men, and definitely elevated levels compared to heterosexual men. And then in terms of treatment, right, because I wanted to get into this treatment space, we see the same low levels of people getting for treatment. So this is among those with an alcohol use disorder, fewer than 1 in, 10 across these groups get treatment for it. So that's sort of that implementation science bit, right? Like I'd spent all this time reviewing the literature on the landscape for treatments for alcohol use disorder or heavy drinking. And even though many interventions exist and have shown to be effective, there's a major issue with getting people to take them up and to stick with them. And then, there's also data showing that the amount you drink is highly correlated with your likelihood of doing well in HIV care, right? Across the care continuum, right? So it's an important health issue. And I said, like, I want to design a project that sort of gets into the space to think about what can we do about it. And Debbie was amazing and helping me guide me through this process and providing mentorship and all the different drafts of my K and sort of, really coalescing these thoughts and communicating them clearly. And eventually we landed on this idea of taking, instead of coming up with my own existing intervention from scratch, we were going to work with 2 existing interventions and think about how they could be combined and maybe work synergistically, right? And Debbie's work, she really emphasized, making things brief, deliverable, scalable, right? And that they could have a home, right? Like a clinical home. But then I also wanted to bring in this part about the social network support, right? And thinking about reducing drinking and doing it in a way that we took advantage of existing social networks. So reviewing that literature, speaking with Debbie and other mentors, I identified these 2 interventions that I want to work with. The first is a social network intervention. It was called Project Engage. It was developed by one of my mentors, John Schneider at University of Chicago. And it was designed specifically for young Black sexual minority men who were newly diagnosed with HIV. And when they'd come into the clinic, they would complete a sort of social network mapping exercise. And through that process, identify a social support member who would be able to be trained to support them in their HIV care, right? And then that person gets invited in and get trained on how to provide HIV care specific social support. And they sort of come up with a plan together for how that could work. And the intervention was, tested in a multi-site trial. It was shown to improve engagement as care as well as ART adherence. But it did nothing to address substance use, right? Including alcohol use. And so we knew from that epi data that many Black sexual minority men also drink heavily. And I thought that could be an area where I could make a contribution. So Debbie had done all this work developing an intervention called Health Call, right? Which is originally it was a phone-based intervention, but it became a mobile health intervention, right? And that targets reduced alcohol use in people living with HIV. And so participants in the Health Call trials would do a brief baseline counseling session, right? Most of the times it involved motivational interviewing, but they've tried different, baseline interventions, and they'll develop some drinking reduction goals, right? And then they're trained to use this Health Call app and encouraged to use it daily to answer 2 to 3 minutes of questions about their drinking behavior, about their HIV medication adherence over the past 24 hours. And then they have follow-up sessions with the counselor again at 30 and 60 days, right? And so with the people that participated, that engaged in the Health Call will now have visualized feedback of their drinking and adherence behavior over those past 30 days, as well as be engaged in like daily self-reporting and getting positive reinforcement about whether they met their drinking reduction goals. And so, Debbie's work's impressive, but like across multiple trials, right, Health Call has been shown to be effective and to reduce drinking. And we just submitted a paper where we showed that it also improved HIV medication adherence, but it really had, never been tailored specifically for Black sexual minority men. And we also thought it could maybe be integrated into this other intervention and to see how they might work synergistically with the social support part. So I'm now almost, 3 years into my K. I'm still working on the first aim as I propose this really extensive formative work to explore whether, these 2 interventions could be integrated, as well as to more effectively address, HIV treatment and alcohol use, but also just to more generally understand like what's happening in these, among these groups in terms of their social networks, their levels of social support, what's their health use yet, what are patterns of substance use, focused on alcohol, but also taking into consideration other drugs. And then how do those translate to, both behavioral and clinical outcomes? And given my, background, I proposed a mixed methods approach. So I, proposed a number of analyses of secondary analyses of existing data sets, as well as, some primary data collection, doing in-depth interviews with Black sexual minority men, as well as their social network members and HIV providers and other key informants, just to get a holistic perspective on how could we really combine these things, how could they work within the lives of these men, and in terms of the services provided in HIV care settings. And we actually we did finish the data collection. Like, we completed 32 in-depth interviews now. They're in the process of being transcribed, and this summer we're putting together a whole team of coders and actually going to analyze and do that and really move into aim 2 of the study. But it's actually all these secondary analyses of existing data sets that's really come to sort of become a real research agenda of its own. And that's what I'm going to jump into next. So one of the first projects I worked on for my K was a collaboration with Patrick Sullivan's group down at Emory University. And we wanted to see if there were racial disparities in terms of lack of viral suppression, comparing Black to white sexual minority men. And then we wanted to see if, we knew that the disparities likely exist, but we wanted to know if certain explanatory factors could actually modify that difference, right? So we leveraged data from this cohort of engagement of Black and white sexual minority men, 400 Black sexual minority men followed over 2 years. And I led the data analysis for this project, and Patrick wrote it up. And this was, a figure that was created for the paper, but it's a little confusing for a slide. So I sort of pull it out here. So from those previous analyses, we found that there were 4 explanatory factors that, if you adjusted for them, they attenuated the age-adjusted association between race and viral suppression by 5% or more. And those percentages are shown here. Those are the proportional decrease in the prevalence ratio once you included that variable in the model. And they're all modifiable, right? Whether or not someone had insurance coverage for their antiretroviral therapy, whether they had housing stability, their level of income, as well as, marijuana use was the only behavioral factor that attenuated. And then when in multivariable results, when you included all 4 of those factors in a single model, right, they almost completely attenuated the racial disparity, right? It made it close to null. And so they combined a 23% reduction or 21% reduction in the age-adjusted prevalence ratio between race and viral suppression. And we felt it was an important finding because it really highlights that these disparities, they're longstanding and they've been shown since the beginning of the epidemic. They really could be reduced if we focused on modifiable factors, right? In terms of like expanding coverage for ART treatment, for housing stability for people living with HIV, a universal income. And then the one thing that interests me most was marijuana use, right? Given my focus on substance use, it's sort of like what's happening, among these Black sexual minority men in terms of their marijuana use. And that finding sort of tied into this other paper, which I worked on with Dustin. And for that project, we had a cohort of HIV negative Black sexual minority men, as well as some transgender women who were enrolled in an STI intervention. And we followed them for 1 year, and the rate of seroconversion over 1 year was 5.3%, right? Over one year of follow-up. And we wanted to look at this sample and see if substance use was a driver of vulnerability. And I think we assumed that methamphetamine use most likely would, because that's been shown in a lot of other studies to be a huge driver of HIV seroconversion. But actually we found that heavy drinking and meth use were not, but actually everyday marijuana use was associated with a more than threefold increased risk of HIV seroconversion. And then we did another analysis where we looked to see if it could be attenuated by other HIV related risk behaviors. And the only one that really seemed to matter at all was having a lab confirmed STI, suggesting there might be some type of biological pathway that could lead to HIV seroconversion. But it really made us start thinking like, wow, what's happening? We had been kind of I'd been focused on alcohol use, and thinking about that. But, it seemed like the data is really telling us, cannabis use might be a huge issue here. And certainly the literature was telling us that methamphetamine use is a major concern among this population. And we just weren't seeing it. So that formative work, made us think like, well, if people are saying meth use could be a major concern among Black sexual minority men, we really looked into the data and we didn't really find any compelling longitudinal work that shows what's happening in terms of methamphetamine use among cohorts of Black sexual minority men. How common is it? What's the incidence? Is it what leads to persistent use? And then Dustin, fortunately, had just come to Columbia and had this really amazing data set of, Black sexual minority men in Chicago, but as well as other studies in the South being followed over 2 years. And they'd really collected some very rich data on sort of the social environmental context in which these men lived, right? By assessing their neighborhoods, by asking them about their social networks and having them map those out. And so I led an R21 proposal saying that we would leverage this networks and neighborhoods cohort and really understand, what's happening in terms of stimulant use, characterize it, as well as identify, social environmental drivers, and then look at how it impacts HIV related outcomes. And it scored really well. Like I had to revise and resubmit, but we got it in the first percentile on the resubmission. And it actually has been great in a lot of ways. We've actually, there's been such disruptions with COVID. We haven't actually been able to complete the aims the way we originally intended, but it provided us resources to really identify a lot of meth using Black sexual minority men and, recruit them into this upcoming wave of the study. And so I think it's a question that remains unanswered, but it's, I think, going to be a really exciting, future area of my research. And then as we were digging into the substance use data for that project, which we were focused on stimulant use, we also noticed these really high levels of cannabis use again, right? Which the other, studies had shown was important, right? And so when we looked at the N2 data, we saw that 1 out of 3 Black sexual minority men reported daily cannabis use. And then another 1 out of 3 reported past month cannabis use, just less than daily, right? And we also knew from that data that we're seeing really suboptimal levels of PrEP uptake, right, in terms of HIV prevention. And so we dug into the literature there and we're wondering, like, no one's really looked at that in depth among Black sexual minority men. And we wondered if there could be a connection. So yeah, we were able to, Dustin invited me to work with him on an R01. And together we wrote this proposal saying that, we see these high levels of use. We know that these are issues. And what can we continue to follow this cohort to really dig more into depth to see whether or not cannabis use is a driver of HIV prevention outcomes. And, Dustin being so productive and amazing, got another R01 funded at the time, right? So that we could also look at this issue of sleep health and whether or not that's associated with HIV positive outcomes among HIV positive men. And it's been amazing because now we have 2 R01s and this R21, and we've been able to sort of leverage all these resources to create an HIV status neutral cohort of Black sexual minority men, enhance enrollment, as I mentioned, get more meth using men, increase the power, and really, follow these men for another 3 cycles. And it's, totally enhancing my training as a K mentee, getting to, we're using respondent driven sampling to recruit these men. I think we're at like 250 right now, hoping to get to 600 by the end of the summer. And we're able to, incorporate all these really exciting innovative methods. We're doing some ecologic momentary assessment. We're collecting biological samples to dig further into that, biological vulnerability, having men do self-administered rectal swabs to look at cytokine function in the rectum, as well as giving blood to look at objective levels of cannabis use in terms of metabolites in the blood, as well as some immune function biomarkers that are available through the blood. And then also looking at HIV related outcomes. So we just submitted the protocol paper for that, which is exciting. And this is going to feel like a lot, but so we got that study funded, and I was sort of paying attention to the RFAs that are coming out, and I saw that there was a lot of interest in understanding drug-drug interactions and how those could impact neurocognitive function, right? And as I was thinking about our cohort, I was like, it's HIV status neutral. About half of the men are living with HIV, half are not. Some are on PrEP, right? Some are taking antiretroviral therapy. Some are living with HIV, but they're not virally suppressed, so they're likely not adherent. And then across these groups, about 1 in 3 are using cannabis daily. And I was like, wow, we have the perfect cohort to look at this issue of drug-drug interactions, right? We have people in all 8 of those buckets. So I was like, let's write another R01. So and our colleague in Chicago had this really compelling fMRI data where they did brain imaging on a subsample of 20 Black sexual minority men, 10 who were using cannabis daily and 10 who weren't, and had them complete the Iowa gambling task, in the fMRI machine using this, goggles thing. I just, heard about it. I've never actually seen it, but I'm going to go do it in a couple weeks here. And when they're, basically perform this risk reward processing task, their brains were lighting up differently, right? The men who used cannabis daily, and they were willing to take much higher risks for the same level of reward, right? And so we got this R01 submitted and then funded to really dig into these potential neurocognitive mechanisms, right? If we think that cannabis use could be a driver of suboptimal uptake of HIV prevention, it could be that it's, impacting, Black sexual minorities men, or just men, users in general's, thoughts about how to manage risk in relation to reward, and, maybe, engage in long-term planning about their vulnerability to HIV infection. So it was at this moment that I'd been trying to do my K to get into this intervention and implementation science space. And all this formative work, which I was super excited to do, led me to what I felt were very much like my bread and butter, right? Causal inference epi. Does X cause Y, right? And I was like, well, where's the implementation science, right? That's where I want to go with this work. And so it was sort of thinking about that, sort of motivated me to write this paper where I've shared this with some of you. I know I'm trying to get Alfredo to read it again, but I was saying, what if we had a method there are methods, there's these hybrid approaches when you're doing a prevention trial where you're focused on effectiveness, but they're saying if you're going to focus on effectiveness and do a whole trial about it, at the same time, you should start collecting data around implementation, right? Would people be willing to uptake this outside of a trial setting? What were providers' barriers or facilitators to incorporating this, trial treatment into their settings, right? And so I thought, well, if we had a method like that, an explicit method to do that when we're conducting observational research, maybe it would get people to start thinking about implementation science a little bit earlier, right? Or in contexts where you're really focused on whether X causes Y, and not as much about what should we do in order to address X or Y or whatever mechanism you think is involved here. So I wrote that paper, and it was just accepted in Annals of Epidemiology. It just came out today, and it was really cool. I'd never written just a methods paper before. Everything had kind of been empirical, but yeah. So I proposed this approach, and we kind of provide a theoretical, justification for it, and then some examples of research where we think that's happening. And some sort of brief discussion about how we think it could be done and what are some of the implementation science methods that we think could make sense to be incorporated into standard sort of observational epidemiologic studies. And I'm really excited about the applications, right? Because the implications, right? Because if people agree this is a good idea and we should start doing that, it maybe could create some more crosstalk between epidemiologists and people doing implementation science research. Could epi training include more exposure to implementation science? Yeah. So yeah, and then yeah, I guess the people on the screen. Um and especially when working among groups like Black sexual minority men, where we're seeing like long-standing inequities, right? And there's a real imperative to conduct like impactful research. I feel like there, should we really prioritize methods like these where you're learning about what to do at the same time as what are the drivers of these inequities? So yeah, so that paper was just published. I'm really excited about it. And the other thing I'm really excited about is we're actually doing it. So we have this cohort of Black sexual minority men in Chicago. We're doing a current wave of data collection, but we're going to keep following them for another 2 cycles. And I've managed to secure some pilot funding, like the CTSA pilot award, as well as a pilot award through the HIV Center to start to supplement activities that can actually develop implementation science methods and measures, and then we'll be able to incorporate them into the next waves of data collection. So for the CTS pilot, we have a discrete choice experiment funded. That's basically like a preference elicitation method, right? Where people, you ask them like, if you were to engage in, alcohol use treatment, like, who would you want to speak with about this issue? Like, and what setting would you feel comfortable? What type of treatment would you prefer? Would you like a pill or an app or, a one-on-one talk therapy or a support group? And how often would you be willing to engage? And sort of by offering them various combinations of these attributes and their levels, what emerges is what's driving their preferences, right? So we could understand if we were to then offer, an alcohol intervention among these groups, like what would be the best way to deliver it? And then we also have a pilot study funded to recruit a subsample of the cohort and do this human-centered design work with them called journey mapping, where you ask people to like sort of walk you through their journey accessing whatever, but we're asking them to describe their journey accessing HIV prevention and care services and talk us through like their emotional and physical, journey into these spaces and how they feel at these moments, and asking them to sort of consider at what point they would be willing to talk with someone about their alcohol use, who they would prefer that is, and just identifying what's called pain points, like opportunities where you could offer intervention where people would be open or susceptible to engaging with discussions or work around reducing their drinking. And we just actually finished data collection for that and are now going to start analyzing those interviews so that maybe for the second or third wave of data collection we really have a great idea of what are men's preferences in terms of getting support for reducing their drinking, and what would be an opportune moment to offer that in the context of accessing HIV prevention and care. So yeah, that's sort of my journey on getting implementation science into observational work. I do want to say I haven't forgotten about my K. We are almost done with the first aim, and I am going to finish it. We're going to analyze this data and actually combine these 2 interventions. So I just wanted to like let you guys know that work hadn't complete, and we will do a trial to see whether or not what we develop works. That's just going to happen, towards the end of the K, but it's in the works, definitely. And then, and I don't want you to think that I only do research. Like there are other things I do as a faculty member, right? I'm serving on these committees. I've been teaching a class for the past 4 years, as Sylvia mentioned. I'm involved in a lot of training around implementation science. There's a institute in Washington University, St. Louis, that I'm a co-director of, as well as an implementation science fellowship at Johns Hopkins. And there's this talk that I've been giving, sort of orienting early stage investigators on using timelines to sort of empowering career planning. And it was something that sort of I came to when I was, in that stage of having submitted my K and waiting to see what would happen, and thinking about, what I could have done at that point to sort of optimize my chances for success and navigate this sort of soft money environment that we're all, familiar with or thinking about getting further into. And I use the tool, and I continue to use this timeline tool to make sure that I have like a very well diversified and balanced portfolio, so that I have the opportunity, to continue doing the research that I want to do in the areas that I'm interested in. And so I sort of talked about some of the projects that have been funded, but there's more in the pipeline, and I think we're about to get one of the protocol funded under the Adolescent Trials Network to do a sequential multiple assignment randomized trial. We're in the process of submitting a supplement to get that officially funded, so that'll be exciting, as well as actually getting back into the global space to do some implementation science work around treatment for substance use among female sex workers in South Africa. And then we just found out actually that we're going to get this Asenze project funded for another couple of cycles. And I'm in discussion with Jeremy Kane and Leslie Davidson about maybe incorporating some implementation science data collection into those future ways of data collection, so that, moving forward, we'd be poised to address some of these issues that we've seen are, salient in this cohort, including, mental health, substance use, and HIV vulnerability. So sorry for the slide interruption, but I hope that sort of provides an overview of what I've been working on, and I'd love to answer questions.
I mean, so it was very impressive. I've known you for years, but I didn't know that. Really remarkable. I was wondering about the implementation side. It seems to me that the connection with the community is through individual. I don't know that, in public health, we would more think in terms of connecting with organizations, with the front line of see everything. Do you have an idea of how you can go from one to the other, or?
Yeah. I appreciate it. Oh, okay, right. Yeah. So if I'm understanding it correctly, it's that the sort of observational implementation hybrid approach, at least the way that I've sort of presented it and conceptualized it, and Alfredo's been helpful in that thinking, is it's really on the individual level, right? Whereas like a lot of public health, right, is at the policy level. And so what are what would be, what the question, I guess, is how could
community
right.
And
No, that, and I appreciate you pushing me to think about that, right? Because I know we've talked about whether or not there could be like a paper sort of laying out examples of how this approach could be used to study policy or like community efforts. And I, because I do like, right, like one thought I've had is, policy gets experienced, right, at the individual level, right? And so, if you have an active cohort, right, and you're interested in understanding whether or not cannabis legalization, understanding its implementation, could you do qualitative work with participants to understand, like, have those policies actually change the way you use cannabis or the way you are able to access it? So it's maybe some work digging into, understanding how policy actually, comes to impact people on the individual level. There's one thought I've had, but I think there's more there that I need to think through, because I appreciate you pushing me on that, because I think it's important to think beyond individual level interventions, right? Because as like the previous research showed, it's really structural issues that are driving most of the inequities, right? It's housing stability, insurance access, income inequality.
So I have a question about the paper that's out today.
Yeah.
I think it's really, I guess it's a little bit of follow-up to what Carol was asking. So you said the paper was based on using observational studies to seed, I guess, to collect early information about implementation processes.
Right.
So I understand if you were running an intervention trial for effectiveness, how you could do that.
Right.
Can you tell me more about how you would do that for using an observational study? I guess I can think about it, but I'd like to hear just more details about how.
Yeah. So my thinking was that, right, like we're looking to understand whether cannabis use impacts HIV, prevention uptake, right? But like the treatment landscape for cannabis use, or the interventions that work to help people uptake PrEP, right, or stay on PrEP, aren't going to change based on whether or not I find there's an association there, right? Like the treatment landscape for heavy cannabis use or cannabis use disorder is what it is, right? So if I feel like there's a promising intervention there that I'd like to learn about whether or not it could have an impact in this population, right? And what are like transportability factors around its, potential effectiveness, or what would be, barriers or facilitators to its uptake. Couldn't I, at the time of doing this observational work, just to see if X causes Y, at the same time start asking those implementation questions around the evidence-based interventions for that would address those issues? And like with that's what we're kind of doing with alcohol use, right? Like with the discrete choice experiment around preferences for the existing, treatments that we know exist for alcohol use, right? Which is, pharmacotherapy and talk therapy and other stuff. So that's sort of like how I was thinking about it. But I'm also, I'd like part of the paper saying like other people are actually doing this, and some people are doing it without calling it this, right? But could maybe naming it as this and sort of laying out a justification for it, maybe increase its uptake, or maybe people that don't see it, the value of it, consider its utility. And I'm hoping it just kind of generates some discussion around it.
Yeah, it's a great idea for the paper. I'm looking forward to reading it and talking about it. It's great.
Thanks.
So really wonderful to see all this put together. I was wondering in your work on observational studies and implementation, even trials and implementation, if you found utility or kinship in the work that's being done advancing a target trial approach, because in the puzzle inference world, when they now have articulated it, it's not only making the observational study like an RCT, but actually following methodologies that you would use in an RCT. And so making the observational study more like what the intervention would be. And part of that, they kind of combine the issue of internal validity and transportability, so that it's not like trying not to make the RCT and therefore the analog, that internal validity, but that target trial. So about the transportability. And I just was wondering, because there was a lot of things in your work and in your paper that kind of echoed that. And I was wondering if you found utility or kinship in that.
Yeah, because I was at APPA, right? And Miguel Hernan presented on the, leveraging observational data to emulate trials, right? And it did make me wonder, like, okay, if you're thinking about using observational data in that way, and I know he was saying that there's very specific conditions in which you're able to do this, and I was also thinking, like, could that same data be leveraged to also understand, like, real world implementation, right? That's where the idea is sort of emerging, right? I'm thinking through it, but that was one direction that I wanted to think about, like, could that data be linked to relevant implementation data so we could not only, emulate trials when conducting observational research, but, leverage existing, implementation relevant data to answer questions around uptake, right? And, or like, contextual, right? Because a lot of implementation science work is like, this didn't work, but maybe it wasn't delivered with fidelity, or maybe, this worked, but then no one takes it up because it wasn't, an acceptable or feasible, intervention in the context of like everyday practice, right? So that's definitely a direction. I think it's important, and it's a direction I want to think about further. Yeah.
Great, really enjoyed your work here.
Thanks.
Look forward to looking into it. So wondered, I saw you were doing SMART, which is great, and wondered if you had thought about, because you're doing the mHealth intervention, thought about micro-randomized trials for creating just-in-time adaptive. So it's similar adaptive intervention, but with more randomizations because of the mHealth.
Yeah. No, it's amazing, like the complexity that they can build in with these trials now, right? With the micro randomization. I mean, I think like with our SMART, we kept it pretty basic because like there is an mHealth component, right? Hopefully working with health call, but like it really was like, the clinical outcome, right? Like whether or not you're reducing your drinking, it seemed like you needed some level of follow-up to see like a meaningful change in terms of what your drinking patterns are.
So in-house kind of one component, but it's not the main.
Right. But I've read the trials where they, within the app, like deliver this message versus that, and the way that it's really like impressive. But I have to admit, like, I had trouble wrapping my mind around how you would analyze that data and actually do it. But I agree, it's like fascinating. And these whole like the just-in-time interventions, right, where you have body monitors and like, and those all seem like more focused on like sedentary behavior and like eating patterns, right? Where, but could it be done in the context of substitute pot? Probably, right?
So my comment is, okay, so my comment is a little bit less about the method stuff, a little bit more about some aspects of the substances. In any case, you talked a lot about the potential harmful effects of alcohol and the knowledge that you're gaining in the cannabis outcomes. In some ways, it's been super helpful to listen to this whole presentation. But sort of like, wow, all of this is just in the KO1, and it's pretty amazing out there. But you're talking about implementation of interventions for alcohol, which I think is sort of increasingly recognized as harmful at this stage. And you've got interventions for cannabis, which is decreasingly recognized as harmful at all, and probably in fact believed by many people as a useful prevention and treatment for pretty much anything. And I was wondering, I started to think about your Chicago cohorts, if you have any data before and after legalization in Illinois 2020. And then, if you're thinking at all about taking these changing attitudes towards the things you want to intervene on and how that might affect the work of the whole.
Yeah, no, that's a great question. And I do think like some of these grants have resonated because of the changing legal landscape and the, increasing acceptability, but also as researchers, and I know you feel this way, it's like, okay, like, yeah, of course, like there's a social justice component, but it's also like, well, are there certain groups who are more vulnerable who these changes aren't necessarily gonna benefit, and we need to sort of understand that, even if public opinion might be moving a certain way. And then a big component of those studies is asking participants about their reasons for use, as well the modalities of use, and really it's like sort of characterizing use more richly, because they're really, I don't, like, maybe Dustin, you might know, but I don't think there's really data on that before. That when the N2 cohort started, was like when they started collecting substance use data was like right after legalization, right as COVID hit. So it's such like an aberration in general. So, but there, I'm sure there's data somewhere. I guess we just don't know where it is. But among Black sexual minority men in Chicago, it might be, pretty small number of people. But that's definitely something that I think that's why we need to think about this implementation approach is like, okay, even if we decide like, oh yeah, like let's offer cognitive behavioral therapy to this group and see how they respond. Like, what if there's absolutely no interest in reducing your cannabis use, right? And that would be important to know before you proposed a trial. And that's why, and I think another, speaks to the value of thinking about implementation and the context of first finding out whether or not this is harmful in terms of HIV vulnerability.
Because we're over time, I think maybe we wrap up and say congratulations, great talk.
Yeah, thank you. Yeah, great. Thanks. Thanks for coming, everyone. Good to see everyone in a room.
Think I do this.
Yeah.
I see you on
Thursday.
on Thursday.
Yeah.
And the general issue of HIV is smart than like.
Yeah, I thought that. Doing.
Have you been, so, I mean, this past weekend,
No, I noticed that.
Just it'll be right back. I'm just gonna run to the back.
Okay, great. Thanks.